Hi, this is Sandeep Jali, Jade Sandoval, and Manos Brilakis, presenting case 281 for the Manual of CTO Interventions. This is a case that illustrates sequential troubleshooting for CTO PCI that involved use of the ReCross dual lumen microcatheter for parallel wiring as well as the laser for treating a balloon uncrossable lesion. The patient was a gentleman with severe emphysema who presented with unstable angina and was turned down for coronary bypass graft surgery after being found to have three-vessel disease, including an LAD CTO. He was subsequently referred for PCI of the LAD CTO. The angiogram shows moderate diffuse disease on the right coronary artery, as well as the circumflex, with a CTO of the mid-LAD. The mid-LAD CTO has a blunt proximal cap, short length but severe calcification in that segment, and the distal vessel was filling mainly through this epicardial collateral from the distal PDA. So our plan was to recanalize the LAD. We had this blunt cap, short length, good quality distal vessel, although there's calcium, and then the epicardial collateral from the PDA. Based on this, our plan was to go Antegrade first, potentially try ADR if we went extra plaque, and then try retrograde if the Antegrade attempts were not successful. We tried first with a filter XTA, but didn't have much luck. Then we did try with a stiffer tip wire. This is a Gaia Next 2. And although it is moving with the vessel, we're clearly not in the lumen, we're in the extra plaque position. So what to do next? We are extra plaque or subintimal, as we said in the past. The two key ways is to either do a parallel wire or do Antegrade dissection reentry. Of course, another approach is to abandon everything and go retrograde. So we decided to proceed with ADR. We used a Gladius Mongo, but it seems to be going a little further out from the lumen than we would like to see. As a result, after several attempts, we decided to try retrograde. So we tried to cross this collateral, but somehow we were unable to do so. So we're back to the Antegrade approach. And the options here are again to do reentry or to do the parallel wiring technique. Traditionally, it happens leaving the wire in place, coming with a microcatheter and a second wire. The variation called seesaw involves using of two single lumen microcatheters, but there's also a variation in which we use a dual lumen microcatheter to do the parallel wiring. And this is what we decided to do in this case, and specifically we use the ReCross dual lumen microcatheter. That is the only one that has two over-the-wire lumens. So the one in the white exits at the tip and about 12 millimeters more proximally. The one in the blue exits at 8 millimeters from the tip. So this way, we can move with either wire, having full control and being able to exchange them because they communicate all the way back to the end of the catheter. So this is the ReCross dual lumen microcatheter, and this is a Gaia Next 2. The Gaia are the most commonly used wires for parallel wiring because of their excellent response. Unfortunately, this didn't work, as we see from the contralateral injection. We're outside. So we came back and we redirected. We took a little more distal course of the vessel, and actually this time we were able to get through, but then nothing would go. No balloon. We tried a tube balloon initially, and no balloon would go. So what to do next? This is a balloon uncrossable lesion. The steps are to start with a small balloon. If that doesn't work, then do the granuloplasty, get more support, for example, with a guide extension or with various wires like the side branch anchor technique. Use a microcatheter. If that doesn't work, go to laser. And if that doesn't work, use atherectomy by exchanging the wire for a roto wire if, of course, this can happen if we can advance the rotablation wire or the orbital atherectomy wire distal to the lesion. And the last step is to use extra plaque techniques to cross this lesion. In this case, we were able to advance a Sapphire 1.0 millimeter balloon, but that would not go distal into the LAD. It gets getting stuck in this angulated segment. The same with a 1.5 millimeter Takeru. Both of those are low profile and excellent balloons for crossing these lesions, but unfortunately didn't work here, likely because of calcification. The next thing we did is we'd use the laser, And the interesting thing with the laser is that sometimes it may not cross itself because it is a fairly bulky device, but it may modify the proximal cap enough that subsequently a balloon will cross, and that's exactly what happened here. The laser itself did not cross, but then the 1.0 millimeter Sapphire did cross through the mid-LAD. We knew it was going to be problematic, so we exchanged after we delivered the microcatheter for a roto wire and did several passes with a 1.5 millimeter burr. And then this is the IVUS showing disruption of the calcium. There is diffuse disease. There's also calcification more proximally. But again, the calcium seems to have been modified enough. So we placed a long 48 millimeter Zions drug-eluting stent, post-dilated with 3.0 and 3.5. And this provided a nice result, T3 flow in the right coronary artery. Multiple lessons from this case. The first one is the importance of changing strategy. Here we had two major problems. The first one was to cross the CTO. The wire kept on going extra plaque. So the solution to this ended up being using the ReCross, dual lumen microcatheter, to do parallel wiring with the Gaia Next 2 wire. The second challenge was the difficulty advancing equipment through the occlusion, and this is often a problem if we cross intraplaque. So what we did for this is tried small balloons with a guide extension that didn't work, but eventually we did use a laser, and the laser modified enough the proximal cap, even though it did not cross, that we were then able to deliver small balloons and then do rotablation and successfully expand the lesion. Thank you.